So Pawan has muted everyone. We'll record the session. Everyone will be on the mute mode. You can post your questions in the chat box. So let me welcome you to the 61st edition of the Thursday Musings. We have an eminent speaker amongst us. Next slide, please. So let me hand over the stage to Professor Dr. Tufan Patil, sir. Sir, over to you. Please skip our introductions.
Thank you, Alim. I usually skip introductions of our dear vibrant moderators, Dr. Alim Siddiqui and Dr. Amrit Patujoshi. Both are professor of psychiatry, but this time I shall mention a little about Alim because his face has changed on the screen and on the slide also. And there is extra line about his 23 publications, 58 faculty lectures, 3 psychiatry book chapters, more than 100 newspaper articles, and multiple talks. And he is a sports enthusiast, and maybe he should have been in Dubai. So with this, I welcome our vibrant moderators, Dr. Alim Siddiqui and Dr. Amrit Patujoshi. And next, our chairperson, Professor Ajay Misra, is professor of the Department of Psychiatry, Mental Health Institute, SC Medical College, Cuttack, which is Center of Excellence. And he passed his MBBS and did his MD from SC Medical College, Cuttack. That is his alma mater. He had been the professor and HOD of Department of Psychiatry in MKCG Medical College, Barampur. One of the pioneer members of the Center of Excellence, ex-president of Indian Psychiatric Society, Odisha State Branch. He has a number of publications in both national and international journals. Very popular PG teacher and also MCA inspector. He is involved in various social services. He is active Rotarian too. Welcome Ajay. Welcome Professor Ajay Misra to Thursday Musings. Next slide, please. Dr. Surjit Prasad from Ranchi. He is presently working as Associate Professor of Psychiatry and in charge Center of the Telemental Health CIP Ranchi. Currently convener of the Youth Mental Health Specialty Section of Indian Psychiatric Society and treasurer of IPS Jharkhand State Branch. He is past joint organizing secretary of ANSIF 2018. He is MD from CIP Ranchi and he passed in 2012. He has several research publications in national and international journals. He is author of several book chapters of psychiatry and clinical psychology. His area of interest involved telepsychiatry, community psychiatry, adult psychiatry, consultation liaison psychiatry. Welcome, Dr. Surjit Prasad. With this brief introduction about the eminent persons, Dr. Ajay and Dr. Surjit, I am handing over the further proceedings of this meeting to the chairpersons, Ajay and Surjit.
Thank you, sir. By the permission of my senior, Dr. Ajay, sir, can I start the session? So your mic is so. May I have the next slide, please? Slide for introduction of. So it's my honor to introduce Geeta ma'am. She needs no introduction basically. So she's a professor of psychiatry at NIMHANS, and she has. We all know she has areas of interest are somatoform disorder, chronic pain, illness, behavior, and women's mental health. She has more than 80 publications in national and international journals. She had contributed in books and monographs, and she has, along with her research projects in the area of chronic pain and somatoform disorder and perinatal psychiatry at NIMHANS. So welcome. I welcome you, ma'am, and it's my privilege to introduce you for a short description about today's topic. Today's topic being psychotherapy of medically unexplained physical symptoms, dilemmas, and challenges. We all know medically unexplained physical symptoms, you can consider it as a flag bearer of consultation license psychiatry. It's very common. So there are many causes that we all know. So, but why it is important? Because most of the cases, like about 20 to 25% of cases, they tend to be chronic in such medically unexplained physical symptom. So this is important. Why therapy? Because we all have experienced drugs has not much role, though it has some role, but not much role. So the onus is on therapy per se. So it's important. And apart from that, the psychological causes like lifestyle, chaotic lifestyle, substance abuse, personality factor. These are the factors which contribute to these medically unexplained physical symptoms. So this is there, and to me, treating MUPS is, first thing is we should acknowledge that the symptom, various symptom of the patient. That is very much important. So we should acknowledge his or her symptom. Yeah, you have such symptom, and I appreciate. Yeah, I really acknowledge that you have this symptom, and our primary goal should be like to help him or her in coping with these physical symptoms. So there are a lot of therapies, like everybody knows CBT, then supportive psychotherapy, mindfulness-based therapies, relaxation. So with these small introduction, I would invite ma'am to please share her views regarding
Dr. Ajay Mishra to give some introductory remarks also.
Okay. Sorry, sir.
Dr. Ajay Mishra, please.
Yes. Yes, everything has been described by my chairperson, my partner chairpersons. I think it is physical symptoms, as you know, are the part of the symptoms that everybody comes to the medical fraternity. And out of those things, 1/3 at least are unexplained. And I think ma'am is there to explain everything in detail. I think we will not be a bar in between. I think over to madam.
Am I audible?
Yeah.
Yeah, okay. I think good evening to all of you. Thanks for joining in, and thanks for a nice introduction. But I just want some introduction about myself and this topic. What is it that makes me, see patients who have medically unexplained symptoms? I do get referrals. So one of the things that probably as a junior resident and as I've been growing in this profession, the more older I get, the more humbling and grounding experience has been seeing patients with medically unexplained symptoms. Somewhere I also feel that they keep connected me to medicine rather than more to the psychiatry, because I think they throw up so many questions, and whatever you do, whatever knowledge you have, they always make me feel, okay, I need to learn a little more about everything at every point of time in every consultation. They make me feel, and they've made me a stronger person, because I think to deal with uncertainty or handling difficult questions, I think that's what has made me feel that, okay, I can now at least talk to them, and then some of the questions I can answer. Now, I think there was a very interesting comment about validation that was made. Okay, so what I'm trying to go take you through this is, I know all here very learned people have joined in, so I don't need to explain about how to do therapy. I'm going to tell you about, it's so easy to read in the books about CBT, what is psychodynamic psychotherapy, but the application part of it is where it is a big challenge. I know we all know CBT is the first level of treatment, but what are the challenges that as a clinician I face? Okay, it's easy. I mean, I can talk to you about research, there's evidence for this, there's no evidence for this, but how do you actually translate it into clinical practice? So let me share this screen and okay. Sorry, I'll just I think I need to be made co-host.
You are the co-host.
Okay.
Madam is not the co-host.
Yeah. Okay, I can see now. Yeah. So as discussed earlier, I think we're going to talk about psychotherapy and management of medically unexplained physical symptoms. What are the challenges and the dilemmas that we face? A brief discussion about, I think, what these MUPS are. It's a very, very broad term, and we all use it. There are so many names for these medically unexplained physical symptoms. They're very common in across all health settings, whether if you work in a general hospital, probably all medical departments and surgical departments will refer cases. And they can be a single symptom to multiple organ systems. This is also important because sometimes in therapy, the more the number of symptoms, the more challenging it becomes. And ever-changing nosology and nomenclature, like we all know that now we no longer use the term MUPS. It's kind of changed into bodily distress disorder and somatic symptom disorders, even though we are kind of using them interchangeably. But medically unexplained physical symptoms are a common feature of somatoform disorders. So somatoform and somatic symptoms. So and our medical colleagues use them as functional symptoms. So there are so many names for it. They're highly comorbid with depression and anxiety. At the same time, people with depression and anxiety can also have physical symptoms associated with a lot of health anxiety, abnormal illness behaviors, and something alexithymia. The reason why I'm mentioning last three is because how they can influence the therapy, participation in therapy and planning therapy, they can be challenges. Now, if we look at the classical definition of somatization, or MUS, is basically communication of emotional distress or psychosocial distress through bodily symptoms. I think it's a very, very straightforward, linear explanation, but we all know that it's not as straightforward as it is. So there are many explanations. So one of the earlier explanation was that in certain cultures, there are no words for emotions or emotional states. But we all know that MUPS exists across countries with all strata, and they are also considered as cultural idioms, expression of idioms of distress. I'm sure all of you, would have heard different ways how bodily symptoms present, and how sometimes it's very difficult if we don't understand the context or cultural context, how they, where they come from. One of the most important thing about MUS is there are a lot of descriptions, about when patients come and present. Like, for example, if I could talk to you about a lady, 30-year-old lady who would come with the complaints. I mean, she's from a very rural background, low socioeconomic status. So she complained of white discharge for vagina, and then she felt that her bones were very weak. So she gave descriptions in her local language, that is South Indian language, but which can actually, and she felt as if, and she had this belief that, somebody had done something black magic to her. But the family also believed, and they took her to various places, they took her to doctors, and so her explanations for her symptoms was she was losing out a lot of, she was becoming weak because of the white discharge. And unfortunate outcome of that was that she had underwent hysterectomy, believing that the white discharge will at the age of 30. And her symptoms obviously did not get better. And, she ended up having a lot of other somatic symptoms that came in. So I think it's important to understand the cultural context, when patients present in. But sometimes when we are on the other side, they can be misinterpreted and misunderstood. What are the features? I mean, they're commonly diagnosed in women, and they're also reported to be common in persons from low-income strata. And there's an assumption that it is better to seek help with physical symptoms rather than emotional symptoms, because we tend to pay more attention to physical symptoms rather than the emotional symptoms. Now, why these are all important? Because these are all the variables that can influence therapy outcomes, isn't it? So, like, let's say women, and if they're from low income strata, and how does it influence therapy? And if you look at general description, is they have probably less education than compared to people who do not have somatic symptoms. Now, with this background, along with that, okay, these are the ways they present. You can also see that they come in with a lot of investigations, or sometimes we feel that they are not investigated. And there's always the concern, by the time they reach psychiatrists, probably they would have met multiple specialists, but still we feel whether we are missing something else. And there are various ways some patients present with distress related to their symptoms. Some patients come in asking for investigation. So it can, I mean, it depends on where you're practicing and how, the health system, how the help seeking happens. And by the time they reach a psychiatrist, I think they would have spent a lot of money on all the expensive investigations. I'll tell you why this is an issue, because when, some years ago, when, a person came with a lot of physical complaints, and then I said, okay, let's do some biofeedback and therapy. And then I said, you have to pay this much for that. It's our rates in the hospital. So, I mean, this was a person, they were from a very lower middle socioeconomic status. And then suddenly there was like, why should I be paying for, discussing about my problem? That was the first question. So, and often there's a lot of disappointment about having, being told that your investigations are all negative. So these are some of the things that are very important when you are doing therapy. When we come to interventions, even though we say therapy, and so what are we aiming at? Are we aiming at reducing the symptoms, or are we aiming at reducing the distress? And our goal might be very different from what the patient wants. And we know that, they would have already gone through use of placebo, multivitamins, and CAM health systems. So the interesting thing is, I mean, I was just discussing with the patient about, generally they would have tried most of the things. And so this is a lady who had undergone Ayurvedic treatment for some massage and other things. And so they gave an explanation to her symptoms that, there was excess heat in her body. And then, so she was quite happy with the system, the explanation, but she wasn't very happy with the kind of treatment that she received. So when they come to us, they have a lot of things going on, a lot of doubts about how these, things work. Now, why psychotherapy for medically unexplained physical symptoms? It's a very interesting thing. They come with a lot of, bodily symptoms, physical, thinking that they have an illness and they need treatment for that. But we say that, psychotherapy is the first line of treatment. Now, are there any guidelines for, like how we have for depression and anxiety? Unfortunately, the guidelines for somatoform disorders are hardly any guidelines. There's one which was there in the IGP. I think it was published in the IGP. But we all know that most of the guidelines, somehow somatoform disorders, the guidelines are very limited. And German, I think there's the guidelines, and Dutch guidelines. But again, the first line of treatment is therapy, psychotherapy. So let's say if it is psychotherapy as the primary treatment for MUS, how realistic are we about it? Now, what coming to, considering psychotherapy as a treatment modality, I think one of the major first barrier probably would be engaging patients in psychological interventions, because they come with a very significantly different model of health and illness beliefs. And motivation and openness is for psychotherapy, because I think motivation is a very important factor. It's not like how we take a painkiller and then it goes away, or you take a pill and then it is better, because here it needs some bit of work from the patient's side also. And a lot of cultural norms and values also interfere with the treatments. So, if I take the person in the context, there are certain things that probably help this person being in this role. So we need to be aware of it. And generally, when patients come in, they are looking for causes not within themselves, but other health professionals have to find cause, something wrong with them, and then treat it. and ability to introspect and examine. That I think is again an issue. The other challenges is I was discussing, I mean, I think there's an interesting aspect that we've, empathy, when we have therapy, one of the thing, very important thing has been empathy. Often it is a challenge with the patients with medically unexplained symptoms because they have significant alexithymia. And it can be a challenge for the therapist also to empathize because they're constantly focusing on the physical complaints, and you need some sort of, okay, you can understand the distress in the first level, but then, when, especially when chronic stomатization, how do you help them to express emotions or discuss emotions? And what we are trying to do is, we are psychologizing when the person is somatizing. So, both these things have to be balanced. And the other challenge is understanding the language. I'm sure all of you probably will come up with so many different explanations for how symptoms present. I'm just using the term pain as a common symptom, but I do know that there are many different kind of physical symptoms. Now, the other thing, I just keep asking these questions, when a person is expressing the distress through body, how can we make this transition to focus on mind? And the chronic the symptoms are, the more challenging it becomes to focus on the mind. And I sometimes, the other question I keep asking myself, you bring out so many conflicts and psychological issues. So are we kind of, probably they're more functional when they have physical symptoms, bringing out emotional symptoms. I don't know, maybe it might increase the initial distress. So when addressing, even though we talked about CBT and so I always kind of wonder, should we address it as a mind concept or should we address it as a body concept? So if you look at the way therapies have been developed for MUPS, I mean, every now and then there is a new therapy that's coming up. The reason I think being most of the therapies, if you look at their evidence wise, the effect size is not great. And people who participate in therapies or probably have a higher motivation. So we really don't know people who don't participate. Probably these are people who are likely to do well in a structured therapy setting. So that these are some of the challenges that I would share with you in terms of doing therapy with patients with MUS. Now, what are the therapies that there's CBT, there's biofeedback, I'm just giving some mindfulness-based CBT, ACT, so many therapies are there. So how do we decide who is suitable for what? Because we know that, sometimes we can use some approach and supportive psychotherapy. So what kind of therapy can we use in different populations? So can I use CBT in a lady I discussed with you who had come post? I would not, I don't think I was successful enough to get her to understand the thoughts and emotions and how they are related to physiological, arousal. So what is it that I would help? I would probably do with her, or I will just share another person. Who do we use CBT? Where do we use mindfulness? Brief psychodynamic. One of the major, probably factor that determines how we choose a therapy is based on our comfort levels or our training in therapy. I think that is probably the important variable in choosing a particular kind of therapy. So I'll just share a case of, this is a person I saw a couple of weeks ago. He's a 35-year-old married man with 2 children, practicing lawyer, has presented with history of pain in the upper back and lower back for 1 year. For 2 months, he's not been going to his work due to pain. He's concerned as it's not getting better. He's been investigated extensively and has been told there are no problems with his. He's consulted an orthopedic, neurology, neurosurgeon, and has undergone physiotherapy with minimal improvement. And he says that he does yoga every day, meditation, and then he's distressed. He reports that that the pain increases during the evening hours more so. Now, he generally, the one of the thing I didn't talk about reattribution therapy, because I think it's one of the most simplified forms of therapy, but there are difficulties in the way it is planned. Implementation of that is quite a challenge. Now, he denies any stress. Often what we see is, even though we say that we want to make a psychological link, but many a times it probably takes multiple sessions to even establish any stress. So he says he has not had any stress or any interpersonal problems, and all the problems have started after he started experiencing bodily symptoms. And I think this is what is probably a more common presentations. And now he's not sure. He's been referred to, so was referred with a note saying that he's been having pain for a very long time and he needs to see a psychiatrist. I think most of the referral, generally what I see is very rarely patients come directly to psychiatrists. So they've been seen by the GP or anyone. So I'm just going to kind of share this video, which basically looks at the initial introduction of the interaction and trying to get that person to consider a therapy. This is not a therapy process, it's just introducing the therapy. I'll try and play the video. We'll see if the volume is okay. If it is not, then probably we can take it up in discussion. I would like actually more interaction, so I'm just going to make a very brief presentation. Okay, I'll just move on to the next slide and see whether this plays out.
Hello, Mr. Kumar. I'm Dr. Amit. I'm one of the psychiatrists working here in this hospital. And nice to meet you today. Hello. I understand that neurologist from this hospital has referred you to us. Did they discuss that, why they are referring you to us?
Yeah, they said that, your pain is not getting better, and I think you should go see a psychiatrist. Okay. That's what they said.
Okay. Thank you for coming today. And how you see seeing a psychiatrist?
I think it's okay, as long as, if it helps me with my pain, it is good.
Let me reassure you that we are here to help you. So allow us to understand you better so that we can try to help you in the best possible way.
Okay.
So can you tell me a bit more about your pain? What's happening?
See, it's been there for the past 2 years, ever since. I don't know how it started, but it's been there ever since I remember. And when I wake up in the morning, it's a little less, but as the day goes on, it keeps worsening and worsening. And it interferes with my work. And when I come back from work, also I have to just lie down on my bed, take rest. So I'm not able to do much activities because of the pain.
Must be hard for you.
Yeah.
I can see. And I was going through notes by a neurologist, and I can see that you have taken lots of medicines, in between a lot of changes also in medicine.
Yeah.
So how did they work?
When I was initially, the medicines would relieve the pain.
Okay.
So temporarily it would give me relief, but over a period of time, the pain would come back again.
Pain would come back again.
Yeah. Okay. So I've taken multiple medications. It's the same story with all of them.
I can see, Mr. Kumar, that pain is from a good time, and you have gone to many doctors, multiple medications have been tried, but you could not find significant improvement so far.
Yes. Okay. Yes.
How it's affecting you?
See, I mean, it's there throughout the day.
You told me. Yes.
And when I go to
Ma'am, the sound is not coming. It stopped just now.
At least 1.5 hours
Is it
for the
better?
pain to get better. So I'm not able to spend much time with my family as well.
Now coming here.
I can see that it's affecting your work significantly and affecting your role also in your family.
Correct.
Any other worries or concern in your mind, Mr. Kumar?
Nothing as of now. If you ask me how's my work, it's good. My relationship with my wife is also good, and I don't have any issues there.
Okay, that's good to hear. And if I ask you that this pain, how it's affecting your mood?
You see, when the pain comes, my mood becomes upset. I become upset.
Okay.
So, as long as the pain is there, my mood is always upset.
So I can see that you become sad, you become upset with the pain coming and increasing.
Yes.
Okay. And what kind of thoughts come in your mind once there is a pain or there is an increase in pain?
Yeah. So when the pain comes, the first thought that comes is, oh, it's back again.
Okay.
And after that, will it ever go? Will I ever be better? Will I be able to do the things like how I was doing before? It feels very it feels like a burden, this pain.
I can see. Mr. Kumar, thank you so much for giving me all this information. And what I understand that is significantly affecting your work, it's affecting your mood, you become upset, and it's affecting your thoughts and other things also. So with this, we have something known as talking treatment or psychotherapy.
Okay.
Have you heard about these terms before?
Just briefly, but I don't know what it is.
Okay.
Actually.
Allow me to explain you that how these things can help you dealing with your pain.
Okay.
And at any point of time, if you feel that I need to repeat it, please tell me. I would be happy to do it again for you. So what happens, as you said, when pain comes, you become upset, you become sad, and it creates a problem. So you can see that pain is not only a body sensation.
Okay.
It's affecting your mood, it's affecting your thought process, your feelings, and your behavior. Is it correct?
Yeah, to some extent, yes.
So with this talking treatment, and sometimes what happens that if people have some kind of tension or anxiety, this may give rise to pain.
Okay.
Or if people are having pain for a long time, it may affect thought process, feelings, and behavior. What is happening with you?
I see. Okay.
So with this talking treatment, what we try to do, we try to understand first that what kind of thoughts and feelings are getting affected, and we try to correct it over a period of time, so that with the pain also your quality of life may improve.
You think that it's going to help me?
Mr. Kumar, what researchers have proven and what we have also seen and experienced, it works.
Okay.
And there is a therapist who's going to see you once a week. One session is around 45 minutes to an hour and generally takes around 12 to 16 sessions. And we have seen that it works and the whole quality of life improves.
Okay.
Do you have any other question for me at this moment?
Not really, but if it is going to help me, I will definitely do it.
Mr. Kumar, then we can fix up an appointment and we can start and go ahead with this.
Okay.
Thank you again for coming today. Thank you. Good day.
The patient was convinced too easily.
Yeah, I'll come to that. Oh, sorry, I don't know how my... Okay, I think let me... am I audible?
Yes, yes.
Yeah, I think let me... the reason why I got this thing is, of course, this happened it was about 2 weeks back when we saw this person. There were a lot of things that we did. I took only some part of it and put it because otherwise it would go on for, it was a half-an-hour interview. I just put some part of it in here. But I'll tell you, I think what we didn't bring into this is we were just eliciting the thoughts. So when he is in pain, what kind of thoughts does he get? How distressed does he become? So, and then he kept saying that, I feel so irritated, so annoyed. Why am I suffering so much? Why am I, going on with this? What will happen? I mean, it just was catastrophizing the entire time about it. So that part, I mean, since it was a very pain related thing, I just kept only this. Like, I think one of the reason why CBT has been, or initially how CBT was supposed to be the treatment for MUPS was basically it was supposed to address the health anxiety. That means misattributions that were going on with the physiological symptoms to signs of illness. That was the main focus of CBT when initially it was planned for somatoform disorders. But later, now it is, there's a lot of discussion about how it is not just, it's about making changes in the attribution. It's more about reducing distress, improving functionality, rather than getting into this mode, it is all psychological or it is all, organic, non-organic, and these things. So rather we focus more on how we can improve the functioning and how actually the thoughts related to the symptoms, the fact that the person is catastrophizing, the fact that the person constantly is thinking about it. Now, when they come to us, probably the whole thing is they come it as a combined experience where you can't differentiate the bodily sensation, the thoughts associated with the emotions. I think it becomes important for us to ask questions related to what kind of thoughts, how does the person feel, and what happens when the person starts, because there are so many negative thoughts and anxiety associated with this, that itself can actually make the physical symptoms worse. So that is the reason why I thought, I mean, of course, this patient is educated. The patient was kind of, already had tried everything. And he did agree to CBT. So he said, I'm at my wit's end. I just need some way of getting rid of my symptoms so that I can function better. Like I said, it may not happen in one session. And generally, when a first assessment, for me, it takes about 30 to 35 minutes. And then we always, say that, okay, we introduce the idea and then they can think about it and come back. So again, there the goals of treatment, I think it's something that I'll just discuss about it. So in CBT, when we think of CBT, I think some of the things which is important is patient has to have an active role. Unless the patient is motivated and motivated to at least reduce the distress and try to work on it, it can be challenging. It is a collaborative approach so that we discuss what is it that we are going to address. Often they come with the notion that the pain, the symptoms have to completely disappear and then I'm going to function. Otherwise, because how can I function when I am in so much pain? So I think that is where it becomes very crucial for us, especially the initial sessions. I think very well put in the introduction that acceptance of symptoms and validation of the distress is very, very crucial, rather than what is it about, is it because of an illness? I think it's important to understand what do the person thinks, whether it's because of signs of an illness, or is it signs of something we have missed diagnosis. It may not be always about sometimes I may not be able to establish anxiety. That's the anxiety is there, that's why this person is feeling these symptoms. So I think accepting that the person is experiencing symptoms and validating that they are suffering so much is very, very crucial. Sometimes initial formulation itself, what are the things, if you're able to elicit some of the catastrophizing beliefs about health, or about like I was mentioning, how they will function only if the symptoms are better, then only I can function, or worries that if I do something maybe the symptoms will get worse. So these, if we are able to kind of elicit those and then make many a times, I think they I don't know, I don't use like how we tell, oh, you have depression, you have anxiety. I'm not sure how many of us actually tell them, no, you have somatoform pain disorder. I'm not sure. Maybe you can tell me if you use it very often. But thankfully, now we have a new category, the chronic pain syndrome, ICD-11. So probably, it's much more easier. So sometimes explaining symptoms becomes very important. I do use, tell them that, what your symptoms are. At this point of time, they may not fit into a medical diagnosis, but there are symptoms which we call them as, at this point, they are unexplained, but it is causing distress. You're not able to function because of that. So we need to work on how we can make you feel better. And I think this term, nothing is physically wrong. Often I do see that even I have used this, but it can backfire sometimes. In a way, it should actually elevate their anxiety that there is nothing major, but the way it is put can also increase their anxiety. So if everything is fine, why is it that I think somewhere, some of them, that it is implied that they are making up these symptoms or they are faking the symptoms. So the first session could be, actually one of the things we start doing would be about identifying what are the triggers, just kind of before we actually challenge the thoughts or discuss the thoughts. Just let's say that's like a waiting period where the person actually has to monitor the symptoms. What is it that, when does it increase? How much does it increase? What happens when it increases? What kind of thoughts come in? What does the person do? What type of behaviors that the person in them? Now that is, if like when this, you tell the patients, we also need to be telling them that because you start focusing a lot on your body, there could be a potential increase in symptoms. I think this is something which is, otherwise they might feel that, the treatment itself making me worse. So I think it's important to address this. And we also need to probably keep it more, any event, it can be physical, psychological, so they just keep, this is like a homework that they are supposed to monitor and bring in. It probably, this will help us to kind of see what has been happening with the symptoms. And somewhere it also probably gives us an idea about to give a feedback to the person also, that when you pay attention, more attention, have you noticed that your symptoms actually worsened? um, but what are the challenges in when we tell them to identify accompanying emotions? Many a times patients come back and say, oh, this happened many years ago, and or it would have happened some time back, and then after some days there could be potential exacerbation. Or the person I was talking about would mention that, when I'm working, I don't feel it so much, but when I come back home, when I'm resting, I actually experience more pain. So this is again probably a way to tell us that how role of attention in experiencing symptoms. And I think this kind of monitoring will also help us to see how thoughts are linked to the physical symptoms, and how, when we focus more on the symptoms, symptoms gets amplified. Now, two things which are important that we need to focus in CBT is checking. I think one of the responses is, whenever there is a worsening of the symptom, they have to get reassurance, so they go to the doctors. They get, probably, I know that many of them get distilled water injection, to probably a multivitamin injections or something, or get an ECG, and then when everything, which is a very transient kind of a thing, and then probably move from one doctor to another doctor. And cognitive restructuring, probably that comes in at a later point of time, when where any symptom they are likely to interpret as a sign of an illness, rather than it could be possible, even the possibility that it could be physiological. We need to take them to questioning, and the whole cognitive restructuring. I'm not getting into how it is done, I'm just mentioning the way, what are the areas that we need to address. Now, okay, CBT, I mean, it does sound very, very structured, very easy, and, probably there's more clarity for the therapist also, and probably the patient. But one of the challenges is acceptance of the therapy. I put it, even though the video which I showed, the person did accept the therapy, not many are willing to accept therapy. The reason being, in their mind, it is about, how will this actually work? So acceptance itself, is a big challenge, and especially in our setting. And the fact that they have to spend so much time, so many sessions, and where we probably are focusing not on the symptoms but making them more functional. So that's another reason. And homework assignments, I think that is one major barrier. The other concern is training. How many of us are properly trained in doing CBT? And many consultation timings time are probably 10 to 15 minutes. Are we adequately trained in CBT? Then dropouts, because it takes about 12 to 16 sessions, so dropout rates are quite high. And especially when there are multiple symptoms and multiple organ systems, it becomes more and more challenging. So I think these are some of the things that I could think of. I'm sure, people who have tried to do CBT might actually come up with more challenges in doing CBT. Like, for example, if you're in a general hospital, often they come with the notion that, medicines are likely to get better. But lately, I feel that the trend is changing, because they say that no, medicines have a lot of side effects, and these are sleeping medications I would not want to take if there's anything else that can be done. Okay, this is something I think commonly used treatment, but like I said, whether all of us have had the training, and it may not work with everyone, and getting homework assignments is a big challenge. There's something that I mean, one of our, sorry, I think I went back, is the second form of therapy that I thought I mean, I find it quite interesting, is acceptance and commitment therapy. I do use some principles of this therapy. One of the PhD scholar actually did a study on acceptance and commitment therapy in patients with MUPS. So the principles are that, okay, you've been having these symptoms for a very long time. What is likely to happen? I mean, it's like learning to live with these symptoms. So accept that this is these symptoms are going to be there. And many a times we see that they take on the identity of their symptoms. It's all about their symptoms. The symptoms define who they are, what they do, how they interact, how they behave. So I think it's important to kind of get them to accept that these symptoms are just part of them, and they accept it, like how we accept other aspects. It's not just positive emotions, negative emotions also we need to accept. So in acceptance especially, I mean, I think there are trials which have been done with chronic pain conditions, fibromyalgia. It is promising, but I think we really need to have more trials before we. And again, here there are some cognitive elements also are used. Cognitive restructuring is done. One of the few of the strategies that actually help is, many of them worry a lot about what their course of the symptoms are in future, what is likely, what has happened in the past. I think teaching them mindfulness strategies and allowing them to accept and not like I mentioned, not letting symptoms define who they are and exact. I mean, recently we've had a lady who comes from a very I mean, I work in a place where the cultures are very different. This lady comes from a joint family system. She had a lot of symptoms, physical symptoms. So constantly the whole family revolved around, I mean, her interactions revolved around her symptoms. So in fact, she's not a very psychologically minded, but one of the things that when we were telling her, about how actually the kind of person she's become after the symptoms started, and I think, she actually kind of took a step back and said, yes, I have become this irritable person. I'm become annoying person because I keep only talking about it. And, they define how I live. Only challenges I face is the kind of metaphors. I mean, if developing specific metaphors to act therapy is something that we need to think of. It has been used in other depression and anxiety, but this is something that I think definitely has a role in treatment of MUPS. Okay. These are the challenges that I already mentioned. Then coming to the other therapies that have been used are attachment-based therapies. So the reason attachment-based therapy, probably the premise is many of the individuals who have MUPS also have history of experiences of adverse childhood experiences, which probably result in them having insecure attachment. So based on this premise, the TBMA, that is the body-mind approach, has been started, where it is done in a group format. So they use a lot of physical activities, and so there is a corrective emotional experience that happens in the group format. So again, this one study, so we've not tried this, but definitely we've done earlier, I think some years ago, there was a trial study on interpersonal therapy in MUPS. So some of these are definitely have a role, because like I said, if you focus too much on mind, probably patients might find it that we are entirely taking away the bodily component and then just focusing on the mind. I think some of these which use both physical components as well as mental components probably help. But then this probably is applicable to some subgroup of patients. However, group format is a challenge in our setting. I also wanted to just highlight this. This is an interesting paper. I think this is probably, I think only one paper I just have come across, Erna Hawks on single session counseling. So we all know dropout rates are quite high. So there is a lot of emphasis on, can we kind of do it in like one long session? There are studies, of course, but is it possible? So this is the person who probably it's from Kashmir. Yeah. And, talked about how actually a single session was quite useful for patients who had physical symptoms. When explanation, it involved giving an explanation for their symptoms, talking about the stressors and how body mind relationship and what is it that they could do, how they could focus, have less focus on their symptoms and get on, improve their function. So, and there is another single session counseling which is more on trauma, especially more focused on women who have had traumatic experiences and then having somatic symptoms. So there also single session counseling focusing on various aspects are there. Now there's a psychosomatic therapy. Like I said, I think there are the challenges, like I mentioned, when somebody comes with so much of physical symptoms, just focusing on mind can be a challenge. So involving physical activity which is done by physical therapists or physiotherapists can actually, along with other components of psychological components, can also be utilized. There are many more therapies. Brief psychodynamic therapy, which I think and I think I just briefly saw a chat where, talking about transference, and I somehow doing brief psychodynamic therapy training is required, where you identify the unconscious conflicts and their feelings and anxieties, and then the associated connection with the symptoms and the defenses. So brief psychodynamic therapy, I don't practice very often. I think maybe 2 or 3 patients, but it was a big challenge to get them to agree to come for psychodynamic, because you need at least about 30 to 40 sessions. Of course, there are many other therapies which probably do not have much evidence. The reason, one of the most important part of all these therapies, who should be doing these therapies? when should we do these therapies, and what kind of patients suit, how do we choose the therapy from the therapies that I've mentioned? How do we go about it? I think these are some of the questions which we can take it up for discussion. The other important thing that I think we also need to address of what we call countertransference. I think these patients can bring in a lot of negative feelings within us. They can frustrate us, they can challenge you, they can say, they can make you feel saying that you're not doing enough, or you're not we are not understanding, we are falling short of their expectations. Now that is another it's a very important thing, because I think we do communicate our feelings in different ways. Sometimes we just hurry up and finish the session, or we just say, you know, okay, we'll talk, or we distract them from talking about their topic. So these are also a very important aspect of therapy that we you know, we need to address. And I you know, in the last maybe so many years, it's very interesting to talk to your residents when they see the cases and the kind of feelings they get. So some of them just come and say, ma'am, this is just a somatoform pain disorder, nothing major. And, you know, it starts from there. So invalidation starts from there. And then somebody will say, no, they've been, I think they get frustrated looking at the file. So these are all the body language. I think we do communicate to them. So I think it's very, very important how we understand, you know, the distress and of MUPS. Okay, so I think I will stop here. This is, okay, this is something that I just put up. All right. I think I finished on time.
Yes.
Yeah.
Yes, quite in time.
Yes.
Can we invite chairpersons for their opening remarks? Thank you so much, ma'am.
Chairpersons for the remarks.
Yes.
Remarks, addition, comments.
Yes.
Yes.
Can I stop
Yes, Dr.
sharing?
Misra.
Yes, madam. Yes.
Thank you, Madam Professor Desai, for your nice presentation. And now it is open for any discussion, any interaction.
Thank you, sir. Dr. Surjit, you want to make any opening remarks?
Yes, ma'am.
Comments?
Thank you so much, ma'am. All the points that were quite practical. These are the practical issues we usually we have to face in our day-to-day practice. So thank you for your presentation, ma'am, and I think we'll have a good discussion about many of the things that culture, like which therapy suits which type of people. So these things need to be discussed. So I think we'll have a good discussion. Thank you, ma'am.
Thank you, Dr. Surjit. I'll start where you started actually. Madam talked about in the first or second slide, she talked about culture. And we have an interesting question in the chat box. You know, India being a multilingual, multi-ethnic, culturally diverse society, how can we deal with this cultural competence aspect? You know, somebody is trained in immense practices in a place like Delhi. Somebody gets trained in AIMS, goes to, you know, Nasik. Somebody is trained in Mumbai, goes to the Nagaland. So how do we take care of all these things, madam?
I think, like I said, I keep learning. In the video that I showed, one of the person is from actually practices in North. So I was just seeing a patient who had a lot of bodily symptoms. I think it's important to ask them the kind of, just get the feel of what the cultural context is. And in fact, it was very interesting. I learn a lot from my residents because they bring in that rich explanations about the place they come from. One is openness. Second thing is, I think we need to keep asking ourselves the questions. I read some of these things from the books about the kind of culture. And for me, the most fascinating thing is the names, because the patient that I showed in the video or the case minute, they all were local language people. So even the pain, the way they describe the severity is very different. The lady that I mentioned, I think it's important. Like, let's say, I'm not very good in Hindi, but I can. If I translate it to English, it would sound as if there is a heaviness in the heart. But I really thought there was, when she described in her language, I thought maybe she's having a lump. Basically, the lump word. But what she was trying to tell me is, that I was scared. I'm interpreted. So, for me, the language is important. The second, I always I talk to them and I get some, of course, I have the advantage of having people around me who are from different setups, different states. So in that sense, for me, it's a little more easier. But for others, I think we just need to know the culture.
Yeah, thank you, ma'am.
It's sometimes a tough act. Sometimes it's a very tough act to really learn the culture and then act accordingly.
Yeah, absolutely. So I have burnt my fingers. I'm in full honesty. I have burnt my fingers. And but like I said, they keep teaching me every day new things. And yeah.
Ma'am, regarding the video, Dr. Mohan Isaac sir has asked if he's available, he can ask this live also regarding whether those were actors or they were demonstrating or they were actual patients.
Hi, sir. It's good to see you. They are a senior resident.
Sir is live, sir. Sir, over to you. Mohan sir.
Yeah. No, you have asked the question for me. I saw the video. It's an excellent video. Of course, the interviewer must be one of the junior or senior residents. But I was wondering whether the interviewee is a typical patient of medically unexplained somatic symptoms. Maybe he is actually a true patient, or maybe he's an actor. I'm not asking about whether it's actor or not. But to me, he appeared too sophisticated to be a person with a multiple bodily complaints. It might be my old experience of working in Sakalwara, etc., where every third patient had multiple aches and pains and all that. They were not looking very sophisticated. But times have changed, so it might be a true patient. That was my doubt. You can clarify that, whether it was an actor or a true patient.
So it was an actor, and he's also an SR. And the thing is, this was a patient whom I had recently seen, and I was quite surprised. And what I'm seeing now is also the kind of profile has changed. It's no longer the very rural, how do I say, very rural, low education. No, this person spoke English. Actually, this person spoke English. And of course, it's a South Indian. It's an English, not his native language, but he actually was quite aware of what CBT was, and we were quite surprised. But I think it's like they're Googled, and of course they Google about everything, and then they had.
That's right.
But I think the referrals also have the quality of the way the referrals are being made have also made a change, because we've been telling them to tell them what exactly, why they are being referred, and what is it that. So in that sense, probably I think it is there.
Thank you.
Regarding this sophistication, I'd say, in my experience, we are now having patients from all walks of life. One of my patients, she had shifted to US, and there she again started having those symptoms. So I think it is a most secular illness that is there. Amrit.
Yes. Madam, if you look at when somebody comes, like we are practicing, we are both in the academics as well as in the private setup. One of the most difficult patients when they come to us are these people, because they come with a full set of files, all investigations done 10 times, 5 times, MRI, every investigation that is possible in the world, that has been done, no respite. And what happens is once they come, the most important or the most distressing aspect is they're dismissed as if they're acting. People, with medically unexplained symptoms are taken as that you have nothing, you're just play acting, and sometimes it causes much more distress to the patient by the way they're dismissed. The symptoms are dismissed actually. So acceptance, like you told, like Dr. Surjit also told when he started the introduction, is the most important part. And that what we had been taught in our medical, in our PG students, that accept that it's a small illness. Don't accept that it's a huge illness. You need an MRI, you need ultrasound, you need 100 things. They think, once you tell them, yes, it's a small illness, it has, and when I see a lot of patients which are referred from the consultational liaison in psychiatry. So anxiety is one of the most important aspects which we need to address pharmacologically also. Because we don't have the, like you talked about single session, we don't even have time for single session, madam. 30 minutes is asking for too much sometimes for us, and then, give them anti-anxiety, explain to them that, yes, this is the medicine for your this. And then once the anti-anxiety drugs take their, effect, maybe 20 days, 1 month, when they come for follow-up, the more amenable to whatever suggestions you give in terms of psychotherapy, in terms of, whatever explanations you need to give, in terms of, the conflicts they have. So, madam, what is your approach when you have pharmacology in your hand, you have psychotherapy in your hand? Do you combine both? What would you prefer, and how would you take?
I think probably first thing, like this person had used all, in fact, the neurologist has given the antidepressants, most of the antidepressants that we have tried. So I really did not have any other new medication that I could try, to be honest. I think that is where I felt that, and one of the thing is, like I said, it's never the very, very clear in terms of, let's say, if you say it's a small illness, it can also be construed as, okay, you are somewhere saying, okay, it's not a big thing. It's a very, very delicate issue, because sometimes they just want, instead of using adjectives, I would probably say, I understand your suffering, but, this is something that can happen, and we would see how to help you. Because the moment we get into this is not something serious, this is not something, it can be a bit of an issue. So I would stay away from those terminologies. I would just say, you have symptoms, we'll see what can be done about it. Many a times I use both. I use pharmacotherapy, but I always explain the limitations, because within a week they'll come back and say that this medication did not work, I just made my symptoms, and their expectations go up. They feel that, medications are like the main thing. It's easier, medications are easier to take rather than attending therapy. I would probably I would agree with that. You need to come, you need to sit, you need to take 1 hour of your time, but medication, just take a pill. So I think it's explaining the role of medicines, what is it is given for, and what is the therapy addressing. So I think that is something that is very, very important, but we can always use both. But it's just that what is it, our target is very, very important. Otherwise they'll end up, I've had patients coming back and complaining, you said, this medicine will work for pain and my sleep will get better. Yes, sleep got better, but pain is still there. So I think it's necessary for us to have that clarity in mind.
And would the opposite approach also work? Suppose I say that these are my medications and they will definitely work, and then they start working. So if I take this help of this placebo factor in addition to the pharmacologic factor, so does this work, or is it counterproductive?
And we don't know. Placebo can work. Like I said, people get injections of distilled water and injections of multivitamin, and they feel better for some time. So I think it depends on the individual, how long these symptoms have been, whether, what kind of again, here comes our therapeutic alliance, your rapport, and with how strong suggestions, how long these symptoms have been there. It may not work in everyone. And again, ethical-ish aspects of giving a placebo. I think this is one of the challenges we did.
Hello, I have got 2 doubts. I think I can raise it.
Sir,
Sure.
all yours.
Any more
All
questions?
yours. All yours.
Yes.
Ali will keep on talking.
My issue number 1 is that nowadays I saw a chat that nowadays there is diminishing practice of psychotherapy But the reverse is true. In every small city, there are a number of psychologists who are practicing psychotherapy in the name of counseling. And to them, the physicians and other experts are sending the patients. Unlike the patient the dignity of which we have seen in video, many patients come, if you suggest them that to go for psychotherapy to this clinical psychologist, they go for CBT, they tell, "Humne usse le liya, we have heard it," and it is nothing. This incident is not small, because everyone had 2 or 3 sessions of counseling by someone who is not a qualified clinical psychologist, and from the entry you cannot decipher anything. And that deconditions them to accept psychotherapy or accept CBT, unlike the patient which we have seen. And the second issue about malingered physical symptoms. Just do not make a compartment that this is malingering and these are the MUPS symptoms. Any patient who malingers has a stress to avoid or has some secondary gain, that is a malingers. And that is the reason at times malingered symptoms may become a mixture of MUPS plus malingered symptoms, and how to approach this case. These are the 2 issues. Dr. Desai, please.
Yeah, I mean, I think, we all have probably gone through the spectrum of malingering, and, it's simply not possible in the first interview to say that this person is malingering. I mean, to be honest, I've had patients who later I have received a quote, this one saying that, this patient was involved in something and then this person came for something. If we begin with that doubt, whether, with that approach that this is malingering or is this somatoform or is this, what is going on here, then probably already we are doubtful about the symptoms. So I think I would probably in the first initial sessions, yes, I would look at everything, in terms, I think role of family in the maintenance of symptoms. I would also look at what are the secondary gains, sick role. All these are important, but I would not use the term malingering straight away. I would probably take, sorry, sir, I didn't get your first question.
My first question was about the patients who have already deconditioned about CBT. They have gone to a
okay,
clinical,
sorry,
not a clinical psychologist,
yes,
who are rampant, who are quite in a good number in all small towns and cities. Students passing out MS in psychology or MA in psychology, they are settling down as a counselor.
And I think that can be a side effect. In fact, that I feel is a side effect. It becomes.
And when such patients come to you, then you tell they are already deconditioned. Yes, CBT, I had 3 sessions. Nothing happened.
Sir, you have raised a very pertinent point, because I think it's not just CBT. People have undergone, probably, like I said, past life regression therapy. Then there are, because everybody can address MUPS. I think they go to various other places. I always ask them what kind of CBT was done, what was told to them. And even in any case, I ask, even whether it is any other diagnosis, we still ask, because I think it is a problem, because many people practice things without actually adequate training. That brings us to the discussion that who is the person who should be actually doing psychotherapy to these patients, especially where there is a medical illness is involved, whereas there is a possibility that you're dealing with something on the borderline. So according to me, I think medically trained doctors are better equipped. I don't know, I might be biased, but many of the psychologists who discuss cases, they also feel, there's so much medical discussion that this person brings in. I find it difficult. So I think we need to have probably a little more emphasis on at least learning CBT principles and practicing some of the techniques. And I think it's very useful. Like what Dr. Amrit mentioned, I mean, even in a single session, some of the CBT principles can actually be done in a single session. And it's, instead of many times I refer them to the person, but they may not reach there. they may actually not attend psychotherapy. So it's sometimes, my personal thing is, I think psychiatrists should be, a better place to do therapy in these cases. That's my personal opinion, but I'm.
I think Mohan sir has put in a word regarding this, that if the general GPs in the periphery, they are trained, many of the things could be taken care of at the primary level only.
I think it's important. There are enough number of enough literature is there on how there are treatments like common elements treatment approach, which is principles of problem solving and handling emotions, and it can be done. Again, here GPs are medically trained professionals. So because when we are evaluating MUPS, it involves, sometimes even a physical examination itself is quite, it reduces anxiety for the person. So I think that's a possibility, because reattribution therapies, I think can sometimes, are being used, but then a lot of criticism has come in because of that. Yeah, this.
Ma'am, it is always a problem trying to explain it to the patient's guardians. If they're saying, this is all just a made up thing, and so how to deal with the caregivers who are bringing the patients, who are saying that this is just to avoid responsibility?
Okay, I think you will get to see two types of caregivers. The caregivers who are more anxious than the person, who actually make things worse for the patient. That's one part of kind of caregivers. They kind of take them along, and they discuss only about their health and symptoms. That's one. They are also problematic, because that itself maintains the symptoms in the person. The other patients are who are very condescending about the symptoms, or they make fun, and including using the term psychosomatic. Like one of the person got, he said, probably this is psychosomatic, which is in a very pejorative way they say it, like saying that, it's not really a big thing. So I think handling those kind of caregivers, I always tell them that this is something very real. This person is suffering. What is it that you can do to make this person feel better? So I start with that, putting the responsibility on them, and how their behaviors can also influence the symptoms. So I think that discussion, of course, it's not, I am kind of putting in, in 3 lines, but it takes some time. And I also talk to the caregivers about how things have been for them. Many of them feel very burdened by caring for, taking them to different hospitals and doing these things, and they also feel frustrated. So sometimes it's important to validate their feelings also, and the fact that this person is not working, there's a financial burden, especially if women. I was talking to this lady who has completely stopped working, so the husband and the son, they want her to get better so that she can start cooking. So that's their concern, and they're taking her to every possible, that actually is not helping her. So I think sometimes involving family is very, very important. I think Dr. Matthew has put in a comment on that. Families, I think we need to address them, but there are other kinds of families which probably are also gaining something by being their caregiver, providing care, and they perpetuate physical symptoms. This I've seen, especially mothers, sometimes perpetuate. I talk to the patient doesn't say much, but the mother will start, okay, this is what this person is experiencing. He's having headache, he's having body ache, he's having. So they become the spokespersons for the individual. So that's an indication that something is going on. This person must be maintaining the symptoms. So
Aline, there are a few questions in the chat box we should take up.
Yes.
And there's a question: how do you explain fear avoidance behavior according to the model of acceptance? This question has come twice.
Sorry,
So,
I didn't get the question. Can I see that?
Yeah. How do you explain the fear avoidance behavior according to the model of acceptance?
Okay, I think one, when we don't acknowledge fear, when we probably what we are trying to do is, especially when there is pain, in anything that exacerbates pain, we avoid. right? Because we don't want to experience that pain. So that's fear is there. If I do this, I am likely to develop a pain. So what do? So I take a step back. In terms of acceptance, you acknowledge that it is okay to be scared. It is okay to be scared, but what is it that I would want to achieve? In acceptance and commitment therapy, it's about finding a meaning and a purpose. So despite you have pain, so I want to still go ahead and do some activity. So you are not trying to suppress your negative feelings, but rather be aware of them, acknowledge the way they are rather than responding to fear. It's okay to be scared, but I will not avoid. That is in the simple form that I've put. But fear and avoidance, more so it comes in CBT, that where you try to address avoidance by gradually increasing the activity levels.
Thank you, madam.
I think there are
there is a question on prestige suggestion. What is your experience on the prestige suggestion in these patients?
I am not very sure about it because I don't do it, so I am not very sure. Maybe others, if anybody is.
Amrit?
I think we'll take one more question. Then we will give madam a rest. She has been talking almost more than 1 hour 20 minutes. So there is another matter. Yeah. Sujit will give you the last. After I finish, I'll ask the last question. Then we will hand it over to you. Madam, you talked about alexithymia, and the question is coming: how useful is it to identify alexithymia during psychotherapy in this MUS patients?
I think alexithymia helps us to probably plan therapy, because if they have difficulty in expressing emotions, if they have difficulty explaining feelings, then probably more behavioral strategies would work, things like physical relaxation activities rather than addressing emotions. And presence of alexithymia can be a negative way. I mean, it's a variable that influences negative. Yeah. So I think that's where it becomes important. And I think when we identify alexithymia, it will also reduce our frustration, because sometimes they can bring in those negative feelings. So
therapeutic nihilism comes sometimes in these cases. That's yeah. One thing I always discuss with my colleagues.
Yes,
never show your disappointment in these cases.
But to be honest, I think we should be aware of it and discussing it with someone, that when you feel that you're not really able to empathize. Yeah.
Over to the chairpersons.
Yeah, Amrit.
You want to ask more?
No, I don't know. Someone had sent a suggestion that if the things can be summarized in 4 or 5 lines, any ma'am, take home messages from your side. Take home message, a few lines.
Okay. First,
Alim will squeeze and squeeze. Alim will, madam, squeeze and squeeze. So you answer in 3 lines.
Okay, I'll say in 3 lines. I just got a chance to go through some of the chats, so I'll just say MUPS is a very broad category of physical symptoms. You can have somatoform, functional somatic syndromes. These are conditions which are real. First level, psychotherapy is doable. And second thing is acceptance and validation of the distress is very important. Third thing, I would suggest that probably having a regular timed consultations is very, very important. I think these are some things that are there. I think that's the least I could say. Yeah.
Thank you so much. Thank you so much. Over to the persons.
Dr. Surjit.
Sir, actually, I had a question. So, can I ask you now?
Yes, please.
Ma'am, actually, initially, like I asked earlier also, what are the can we decide which patients will, which therapy will suit which patients? Any typology of patients, these type of patients will have will benefited from CBTs, some will benefit from ACT or mindfulness. So anything.
Okay, I think CBT, I would probably see in my first or second session, if I feel that they are able to kind of describe their thoughts, they are able to be aware of thoughts and emotions, and they recognize if I'm able to kind of make a link that this could, then probably CBT helps. If they have one or two symptoms, one or similar kind of symptoms. If there are multiple symptoms and going on for a very long time with chronic, then ACT seems to be better, but there is no evidence. This is more for my clinical experience.
Thank you so much, ma'am. Because what we see in our practice, metiform disorder has usually chronic course. So that question many times comes in our mind. So to me, it was a great learning experience. Thank you so much, ma'am, for teaching us all the practical tips that we actually need in our daily practice. Thank you so much for that, ma'am. Ajay, sir.
Yes. Thank you, madam, for your nice presentation and very long discussions and beautiful discussions. And to conclude, I think there are two things that attracted me. One is not to investigate for this MUPS. And as you know, this unexplained physical symptoms and explained physical symptoms, and the prospective study says that both outcome are almost same. And as you know, all clinicians would agree with me that we are also scared for this type of patients, and we can rank them as headache patients, and everybody is scared of these patients. And so another thing attracted me that in your therapy sessions, you said nicely that this collaborative approach and between clinician and patients, and rightly it should be communicated well, so that this type of patients will definitely improve, and like other explained patients, and we are giving so many psychotherapies and all these things, and these things are up to the same level, they can come up to the same level. I think it is very nice. Once again, I thank you. Thank you all.
Tufan sir. Sir, unmute yourself. Unmute yourself.
I have made my comments already, and it was very nice listening to Dr. Geeta Desai. And I don't want to come in the way of her dinner by extending the session. Happy dinner, Dr. Desai. Over to Dr. Amrit for Kodak.
So thank you so much. It was really a wonderful session. So simple, so lucid, so clear. It's as if we were just being taken bit by bit, part by part. Nothing complicated. A very, very complicated disease or the disorder which has been very, very simplified. Thank you so much, Geeta madam. You have been brilliant, and we expect you to please grace our Thursday musings again in this year only. We will be inviting you again. Thank you to our Professor Ajay Mishra sir. You've been wonderful as a chairperson. Thank you, Dr. Surjit, my dear friend, and the Mahendra Dhoni of if you look at cricket, he's our Mahendra Dhoni, Singh Dhoni. Hit sixes again. Thank you. You hit sixes today also with your brilliant observations. Thank you to our musings team, Dr. Alim, Dr. Tufan sir, as always guiding us. Our Rucha and Saji and Sharda. Thank you, Mohan sir. You have been so active with us. Thank you to all our followers. We had more than 300 people who had participated at a peak of 220, and it is really wonderful. When we have webinars, every second, having this big audience speaks highly of madam. So thank you so much. Next week we will catch you with another great session of Thursday musings. Till then, have a great dinner. Have a great weekend.
Right, Mohan sir is there. I think we can have his pulse of wisdom. Mohan sir.
Thank you. Thank you, Alim. I think Dr. Tofan Pati has already wished us all happy dinner, but I would still, since you asked me, I'd like to make 2 or 3 comments. First is, that I'm just an on and off attender in Thursday musings. But I must say that every time I attend, it's been a very, very informative and educative talk. Today, I, of course, logged in because I wanted to listen to Geeta, whom I have known for a long time. I'll come to that in a moment. But what I want to make as my first point is, being an on and off attender, I don't see what is happening every week. And today, the first thing I noticed is a new persona for Alim Siddiqui. Because last time when I saw him, he had a nice very handsome beard and mustache, and today is cleanly shaven. Maybe there is some significant event has occurred in his life. I'm not going to ask him that, but that was the first thing I noticed. Now, the Alim, I must tell you something. When you ask retired old professors to make a comment, there is a danger that they will talk more about the past than about the future. And because it is nostalgia, you think of very good things, etc. And I just want to say two things. One is many years ago, and it is now more than 30 years, when I took over as the head of the Department of Psychiatry from Dr. Srinivas Murthy, who was also in the meeting. I don't know if he's still here. One of the first batches that I had the privilege of selecting as the head of the Department of Psychiatry was Geeta Desai's batch. She was a topper everywhere. She was a topper when she joined the institute. She was a topper all through. I think she was a topper in the MD exam, which also got her the gold medal, etc. But what I wanted to say is that not all people who are bold like her do a PhD on a condition or a disorder which is very difficult. Many people have already mentioned that nobody, not the general practitioner, not the PhD doctor, not the psychiatrist, nobody wants to see a person who has a somatizing problem. It is being described. Gita said it is very pejorative, but it is said that when a somatizer comes into your room, it's a pain, whether it's a psychiatrist or anybody. You don't want to see them. And also, Amit mentioned, how you give an anti-anxiety drug, you don't have time, etc. But Gita is somebody who has not only given the talk, but she has done a very extensive work. She has done PhD work, and she has. The other point is, of course, once you are already an MD and a PhD, where MD and a professor going up in the hierarchy, why do you want to do PhD? But Gita has done the PhD, and this is because she loves this topic. She has published on it. What she taught today is only a very small fraction of her expertise on this topic. So it has been a great pleasure to listen to her. I nostalgically remembered when she came for the first MD interview, and ever through she has been a topper, and she is now a very distinguished professor of psychiatry at the National Institute of Mental Health and Neurosciences. My previous speakers have all complimented her for simplifying otherwise a very complicated topic. Even for the DSM-5 and ICD-11 classificatory teams, this has been a pain. They have not been able to classify it properly, in a proper way. And Gita referred to that. Now, the second point is again a very nostalgic point. And that is when I began my MD career nearly 40 years ago. One of my very distinguished classmates, who is now a very distinguished professor of psychiatry at the Harvard Medical School, I'm referring to Macheri Keshwan. He was known as MS Keshwan. We both did our MD together. That is not what I'm saying. But one of the earliest papers, Keshwan is now, written maybe 500 papers, is known as a schizophrenia researcher, etc. But those days, Dr. Kapoor was the professor of psychiatry. He was interested in community psychiatry. Everybody was posted to Sakalwara. It's a rural mental health center. Keshavan and I wrote one of mine as well as his earliest paper in a journal called Tropical and Geographical Medicine. And the title of the paper was Ill-Defined Somatic Symptoms in a South Indian Rural Clinic. When we ran the clinic at Sakalwara, every second or third patient would have multiple aches and pains, fatigue, tiredness, etc., etc. And also one of the first things I had heard, because I had never worked in rural areas, and that is what Geeta mentioned quite early in the talk: white discharge per vagina. Every third woman will have white discharge per vagina. They will say, this is what is causing all the problem for me, fatigue, etc. So we both have had interest in the somatic symptom complex. The riddle has not been solved, it continues. It is a problem, it takes time. Even for the psychiatrist, it takes time. Geeta mentioned 30 minutes is the minimum. Even if you give your psychotherapy in one session, it's time consuming. Amrit said that a lot of psychiatrists in our country cannot afford that kind of a luxury or spending the time. So it continues to be a problem. The proportion, the prevalence of the problem is, if at all anything, it is high. people are disabled, they take leave, etc., etc. And to this list, one or couple of things that I have read recently. One is, of course, the chronic fatigue syndrome, which is reported from Europe, which again is psychiatric, neurological, or is it a post-viral kind of a thing? The reason why I'm referring to is, in the recent days, there have been at least 3 or 4 papers which I have read about the long COVID, the post-COVID. In fact, one of the most recent papers, they say, what is the typical symptomatology of the so-called long COVID syndrome? And the paper says at least 200 symptoms have been reported in different parts of the world. Fatigue is a classical symptom. Pains are the brain fog, mild, something similar to mild cognitive deficit, or what has been described today in the literature as brain fog. So this is also, Geeta already mentioned that multiple bodily symptoms of unexplained etiology. It's a bag of various things. Now you can also put not only chronic fatigue syndrome, but long COVID, whatever that is. Again, many people who are chronic fatigue syndrome enthusiasts are saying, okay, post-COVID again is a post-viral, maybe myalgia, fatigue, etc. So the riddle only continues. I may have added to the confusion, but thank you very much, Alim, for asking me to speak. Geeta, it has been a great pleasure to not only see you, but listen to your excellent talk. Thank you very much.
Thank you, sir.
Thank you so much, sir. Thank you so much. Sir, with your permission.
Yeah, madam, we'll call you again.
Murthy sir would like
I
to
hope you
contribute.
I hope you liked the
We'd love to listen from you, Murthy sir.
Geeta madam is something telling. Madam, you like the platform?
It's fantastic. I think I've learned a lot from the chats, a lot of questions in the chats, and all of you, fantastic discussion. I think it's been a wonderful experience for me.
Thank you so much. Good night. Pleasure having you here.
Dr. Murthy, will you please enlighten us? So we can conclude the remarks by Dr. Mohan Isaac have been excellent. And I always consider it a great remark, because actually I find we have to potentiate those doctors to whom the patient should go first. Let them not be afraid of MUPS, let them deal with it. They have to be potentiated. Otherwise, this gap will never be made up so soon. Till it is made up, that has to be the strategy. Potentiate the peripheral doctors, GPs. Okay, Amrit, we can go. Amrit is here.
Sir, with your permission, we can close the meeting now. And finally, thanks once more to our presenter Geeta ma'am and the chairpersons.
Thank you. Thank you, ma'am. Thank you, sir.
Yeah.
Good night.